Good afternoon. I'm Paul Perito. I'm from Coral Gables, Florida. Thank you very much, Coloplast, for inviting me to speak today. I've been invited to speak about the minimally invasive approach to penile implantation. This year, I'll present a retrospective analysis of my most recent 1,000 cases. And in those 1,000 cases, there's been one thing that's been consistent, and that's been the procedure, addressing specific things such as using no Foley, limiting my dilation techniques, making sure that my reservoir is behind transversalis fascia, using an artificial erection at the beginning of the procedure, and finally the use of the drain. And our results, they were good. We limited our morbidity. Our infection rate was only 0.91%. I had 2 distal urethral injuries that were repaired primarily at the time of the procedure. And finally, I had 2 scrotal hematomas that were evacuated. I think that the most important thing to see in this paper, when it comes to the efficacy of this procedure, is how quickly my patients got back to normal sexual function. Approximately 82% of my patients were back to normal function at 4 weeks, and the rest by 6 weeks. That to me tells me that the procedure is efficacious, expedient, and safe. There's only one question in medicine that's answered 100% of the time the same way. When a patient comes to my office and is being evaluated for a penile implant, I'll do a penile stretch test. Whenever I do the penile stretch test, I say, I'll bet your penis used to be this long, and I'll go about 1 inch longer than the penile stretch test. 100% of the time they go, no, it used to be this long, and it's about 3 inches longer than that. We all know that when you render a man impotent, for example, with a radical prostatectomy, over the course of the next 14 months, he'll lose anywhere from 0.5 to 5 centimeters in length. So what I wanted to do was find the best predictive index to give a patient a realistic view of what they're going to have postoperatively. And I presented this last year at Chicago. And what I did was I took 53 patients and I measured their artificial erection, the penile stretch test, and finally what they had at the end of the procedure. And not surprisingly, the best predictive index was the penile stretch test. So now when a patient comes in my office and they want a penile implant, I'll do the penile stretch test and I'll say 72% of the time, this is what you're going to have postoperatively. And if they don't like that, they should probably not get their penile implant. Like I said, I was asked to talk about this minimally invasive approach to the penile prosthesis. The infrapubic approach, I'm here to tell you, the one championed by Mulcahy, Borges, and a lot of other doctors, is alive and well. If you look at this slide, I'm going to tell you a few of the nuances of my case that I think make it an even better procedure. But first, you'll see that we're missing a couple things. There's no Foley catheter, and there's no Scott retractor. Dr. Balala referred to the risk of nidus of infection in the urethra, and the way that I place my reservoir, I don't have to worry about draining the bladder, and we'll go over that a little bit later. I also do not use a Scott retractor, which limits, actually reduces the cost of this procedure. My penile pack costs $72 to the hospital, and these days, cutting costs is absolutely essential. I start my case with an artificial erection. This, I think, is probably the most important aspect of this case. The artificial erection accomplishes 3 things. First, I can identify areas of pathology before I start the case. If there's dimpling in the corpora, if there's a penile curvature that's going to need to have a plastic correction of angulation of the penis addressed that I did not know about, I'll find out about it at this time. The second thing that it does is that's my dilation. I don't need to do any dilation. There's no serial dilation in my case. The dilation is accomplished by the artificial erection itself. We're in the process of now getting an IRB to see if indeed this translates to less cold glands and maybe more sensate when it comes to the glands during coitus. Finally, if you add a little bit of lidocaine to the mixture, it'll make it easy to do this procedure under local anesthesia. And nowadays, I'm probably doing about 90% of my cases under local anesthesia.